In this presentation, we will discuss a number of issues regarding artificial airways, and in particular, the problems with current cuff management techniques. We will look at how the practices of cuff management may play a contributing part on secretion drainage into the lower airways, what steps may be considered going forward in an effort to protect from secretion colonization and ventilator-associated pneumonia. We will look at the problems using cuff management practices, their contribution to tracheal damage, and possible solutions to address these problems. So for today, we'll look at multiple topics that include the range of problems, the evidence, current cuff management practices, and their contributing features to the identified problems, and a clinical tool that may lead towards improvement in desired outcomes. There are several reasons to address cuff management, including the continuing problems that lead to ventilator-associated pneumonia. Considering the consequences of acquiring VAP, including higher mortality when compared with patients without VAP, increased costs, ventilator and ICU days, we need to approach the topic of cuff management as an opportunity for improving outcomes. Despite an aggressive campaign to increase compliance to the VAP bundle elements, many hospital rates of VAP do not appear to have been impacted and continue to exceed NHSN standards. So because secretions are at the heart of the problem to VAP, our strategy should continue with a focus on prevention in terms of not allowing accumulated secretions above the cuff of the artificial airway to leak below the cuff. The current recommendations are to maintain cuff pressure above 20 centimeters of water to guard against secretion leakage. The American Thoracic Society and the Infectious Disease Society, in their joint guideline for managing adults with VAP, and with recent acknowledgement from CDC and JCAHO, make as one of their Level 2 recommendations the maintenance of cuff pressure to greater than 20 centimeters of water. Current literature looks at the problem from the perspective of current practices. In this article, Soleil looked at the effects of intervening or not intervening by adding and removing air in the cuff to maintain cuff pressure within the recommended range of 20 to 30 centimeters of water. Her study found that without intervention, cuff pressure was outside of the recommended range 52% of the time. By intervening, by adding air mostly, cuff pressure was outside of this range only 11% of the time. However, an average of 8 adjustments, which was primarily the addition of air into the cuff, were required to maintain this recommended cuff pressure. Therefore, the conclusions as noted state that intervention in the form of human manipulation of the cuff and their time are required to keep cuff pressure stable. Also, cuff pressure, she found, does decrease over time without intervention. This diagram demonstrates the location of the problem that we now aim our focus at, which is to say prevention of allowing contaminated and colonized secretions from entering the lower airways from above the cuff. The current belief is that by not preventing microaspiration or bolusing of these secretions due to current methods and practices of cuff management, we may be able to prevent pneumonia similar to that which is displayed in this chest X-ray. There are other practices that are of concern, and these practices lead to excessive cuff pressure applied to the trachea. The problem can be described in the following way. It takes only 15 minutes in a normotensive patient for tracheal damage to occur with cuff pressure above 30 centimeters of water. Cuff inflation that results in excessive cuff pressure appears to be a common problem in the OR, as the investigators of this study demonstrate. As we seek to help with this problem, a practical solution is recommended to measure or monitor cuff pressure intraoperatively. In this article from the ENT profession, the significant concerns are raised. These concerns acknowledge the problems that they face due to consequences of excessively high cuff pressure. Here we see one extreme example from uncorrected high cuff pressure with a slide from autopsy. Cuff pressure was allowed to remain high for several days, leading to the perforation and tracheal expansion that occurred as a result of excessive cuff pressure. With the background that explains the problems associated with current practices of cuff management now established, we will now move forward and look at the current standard of care. We will challenge why we consider these practices to be the source of these clinical problems. We will then look at possible solutions and alternative new products designed to address the limitations of current practices and techniques. First, we need to look at the statement in the slide which identifies the long-standing goal when determining reasonable cuff management practice. Few would challenge that prescribed tidal volume is a basic requirement. Most also agree that sufficient cuff pressure is needed to seal the trachea for microaspiration. Finally, it has been taught for decades that tracheal perfusion must not be impeded, and it is conceptually agreeable that we want to not cause tracheal damage created by high cuff pressure. So in summary to the previous slide, we must see that we are clinically attempting to manage the cuff in a narrow range of pressure. So in other words, to protect our patients from VAP and tracheal damage, we are attempting to maintain a narrow cuff pressure range within what I call the sweet spot of between 20 to 30 centimeters of water for the majority of our patients. Considering this narrow cuff pressure range restriction, we need to look closer at how we now achieve this goal using the popular intermittent approaches as compared to continuous cuff inflation. The intermittent approach includes minimal occlusive volume or minimal leak technique, syringe inflation using the popular Posey cuff inflator, and finally the syringe gauge stopcock assembly methods. From the perspective of continuous inflation, we will look at the Pressure Easy device, which has been available for many years. ARM Medical also has a fairly new electronic device for continuous inflation and measurement called the Python. This product called the Python is a new approach without data to reference and a high expense, so we will not discuss this method in this slide presentation. We have several commonly used devices and or techniques listed on this slide that have been the cornerstone of cuff management practice for many years. Minimal occlusive volume or minimal leak technique, simple syringe inflation with or without measurement, Posey cuff inflator, and Pressure Easy represent the vast majority of devices and techniques available to practitioners. Minimal occlusive volume technique, or MOV, is one of the most popular, if not the most popular, and extensively used cuff protective techniques we know of. The evidence shows, though, that MOV has clinically significant consequences. Consider that the first action of MOV is to deflate the cuff. This allows accumulated secretions above the cuff to flow below the cuff, which is exactly the specific action that current recommendations want to prevent to help protect against VAP. The next action of MOV is the inflation of the cuff, sufficient enough to create a seal of the cuff with the trachea. The literature demonstrates, though, that this action is unreliable and results in cuff pressure being higher than the recommended target, which would otherwise protect the trachea from damage. Another popular method for routine cuff checks is this assembly of a syringe, stopcock, and pressure gauge. Although a simple design, it should be appreciated that on connection to the pilot balloon, the pressure gauge becomes pressurized with the air drawn from the endotracheal tube cuff. The endotracheal tube air to fill the pressure gauge is sufficient to decrease the cuff pressure by about 10 centimeters of water. Considering that 20 centimeters of water is the minimum cuff pressure to help prevent against secretion flow from above to below the cuff, it can easily be seen that this loss in cuff pressure from this technique is sufficient to potentially contaminate the lower airways with colonized secretions. It should also be noted that after cuff pressure is adjusted appropriately, there is no protection against a rise in cuff pressure due to compression of the cuff as, for example, the patient is turned, or for loss in cuff pressure due to, for example, a check valve leak. Simple syringe inflation without measuring cuff pressure is another common practice. The clinician often relies on palpation of the pilot balloon to estimate the adequacy of cuff pressure. Unfortunately, the literature shows that regardless of profession, the estimation of cuff pressure using this technique is not a teachable skill, and it is a highly unreliable predictor in achieving safe cuff pressure. Cuff pressure is often excessive using this technique. Coupled with the administration of nitrous oxide intraoperatively, which diffuses into the cuff and builds up extremely high cuff pressure, patients are unprotected from acquiring tracheal damage due to these practices where pressure is not measured and relieved. As you know from a previous slide, it only takes 15 minutes in a normotensive patient for tracheal damage to occur with a cuff pressure above 30 centimeters of water. This is a slide describing the current practice of cuff inflation and estimating adequate cuff pressure by using the pilot balloon palpation method. This study showed that the skill is not reliable in the EMS profession, which are similar to the results from practicing ER, MDs, and anesthesiologists. Another popular method for routine cuff checks is the Posey cuff inflator. Similar to a previous method we discussed, it should be appreciated that on connection to the pilot balloon, the pressure gauge is filled from the endotracheal to cuff air. The volume of air to fill the pressure gauge is sufficient to decrease the cuff pressure by about 10 centimeters of water. Secretions from above the cuff can easily flow into the lungs using this method of intermittent cuff checking, and potentially contaminating the lower airway with colonized secretions. Similar with other techniques discussed, after cuff pressure is adjusted appropriately, there is no protection against a rise in cuff pressure due to compression of the cuff or from loss of cuff pressure due to a leak. Pressure Easy is another cuff management device, but unlike previous methods and devices for routine cuff checks, Pressure Easy is designed for continuous application of pressure to the cuff. This device is connected to the pilot balloon and remains attached to apply between 20 to 30 centimeters of water of cuff pressure. The manufacturer indicates that each Pressure Easy device may be delivering 20, 25, or 30 centimeters of water. There is no adjustment if the device is delivering 20 centimeters of water to make it deliver 25 or 30, if the patient's compliance, for example, requires a higher pressure. There is also not any protection to compensate against cuff compression that will apply higher cuff pressure than desired to the trachea. So that brings us to a device that is designed to address the known problems that we have not been able to solve using the techniques and devices available to us for many years. Cuff Sentry was designed to meet the current ATS and IDS ventilator-associated pneumonia prevention recommendation to maintain cuff pressure greater than 20 centimeters of water, or above. It is also a unique device that will continuously display cuff pressure and hopefully raise the clinical awareness and detect unintended cuff pressure applied to the trachea. It is also a device that limits use to a single patient, with the intention of preventing cross-contamination that occurs now from using multiple patient-use products. So what does Cuff Sentry do? Cuff Sentry is set by the clinician to a desired cuff pressure. The goal, as with any cuff management technique, is to assure tidal volume delivery, prevent secretion drainage into the lungs, and avoid, by monitoring, application of excessive cuff pressure to the trachea. So by having continuous awareness of cuff pressure and maintaining it within the recommended 20 to 30 centimeter of water range, we anticipate improvement in outcomes when compared to the current intermittent check method. Please read the following instructions on the slide for using Cuff Sentry. Click your mouse or press the Enter key to continue. This slide describes warnings that each of us should be familiar with. Click your mouse or press the Enter key to continue. In this slide, we outline the anticipated outcomes comparing blind inflation and MOV technique against the concept of pressure-regulating air-filled artificial airway cuffs. Click your mouse or press the Enter key to continue. The following and last 3 slides have a list of questions that you may have with responses. Please click or press the Enter key to advance, and thank you for accessing this training module on cuff management.